Welcome back, everybody, and welcome to Chapter 9. This is our Community Needs Assessment PowerPoint presentation. I have some new technology set up. IT came in, took pity on me, but I'm trying to figure out I have 3 screens. So if I'm looking back and forth, I apologize. But we're going to get straight into our topic of the day. I hope so far you guys enjoyed Module 1. This is your first for Module 2. As always, please don't hesitate to reach out to me if you have any questions, comments, concerns, snide remarks. I will take all of the above. All right, so we're discussing our community needs assessment. In this section, we're going to learn how communities figure out what their health needs really are, as well as how community paramedics like you guys can use that information to care for the entire patient, the whole patient. You'll see how public health departments and community paramedicine programs identify gaps and create plans, as well as connect patients to resources. We're going to cover 2 types of assessments. We're going to explore mapping, data collection, and then we're going to move into how all of this ties directly to the work that we do here in Western North Carolina, because the large majority you are from WNC. And heads up, this is a heavy chapter for the IBSC. So please pay close attention to the sequence as well as those key definitions. Okay, so our Community Health Needs Assessment, or the abbreviation is CHNA, it's a formal review of the demographics and the health status of a community. It's usually carried out by the local public health department, but the process is not done in isolation. A steering committee is usually formed, and that includes healthcare providers, social services organizations, community-based stakeholders. For us in this region, think about Henderson County's Public Health Office. They pull in partners like Mission, Advent Health, and Community EMS to assess our regional needs. Most of you all have already had this done for your respective areas as well. So please ask to see that if you have not yet seen that. So the purpose of the CHNA is simple but powerful. It helps the community prioritize what health measures they will undertake. What are the greatest needs in our area? To get there, most communities use a stepwise approach. They assemble the steering committee, create the community map, verify the collected data and that it's accurate, and then organize the data into something meaningful. So a little exam trick. If you see a question asking what's the first step in a CNHA, the answer is assemble the steering committee, not the map. The map comes later. When we say assemble a steering committee, we mean gathering a cross-section of leaders, hospitals, physicians, public health organizations or officials, elected leaders, local universities and colleges. In our region, that may also include UNC Asheville's public health program, county commissioners, or even Blue Ridge Community College faculty sitting on an advisory board. The next step in building a community map, this is more like a geographic outline. It's a powerful interactive tool created by a trained assessor that usually displays health data in layers or overlays. It is a powerful visual. Those overlays might include demographics like age, race, and income, the prevalence of disease like diabetes or COPD, life expectancy by neighborhood and healthcare organizations like ER visits or those 911 calls. In Polk County down the mountain from here, for example, you might overlay the higher COPD burden in Saluda with transport times to Pardee or Spartanburg. Maps like these aren't just for public health professionals. They're designed to be used by policymakers, journalists, consumer advocacy groups, and researchers. Sometimes they can even stand alone as an easy to understand infographic for the public to see. These maps are incredibly useful because they can show you where the problem clusters are. They might highlight areas of high risk, like neighborhoods with the highest rates of stroke or high utilization, those high callers, like areas where EMS is called repeatedly for the same conditions. That's where we, as the community paramedics, can plug in with targeted programs. Example, a map showing high ED use plus chronic disease is a classic red flag for our CP interventions. So where does all this data come from? A variety of sources, the national, regional, as well as local. The U.S. Census Bureau is often the most robust, but don't forget local and our state health departments. We utilize them heavy as well. In North Carolina, the county level data is gold when you are building these maps for our demographics. That demographic data includes population size, race and ethnicity, age distribution, income levels, employment, and education. Here in Western North Carolina, you'll notice differences when comparing our rural Polk County to more urban Buncombe County, and those differences do matter when you are designing your services for your particular area. The CDC, Center for Disease Control, they provide another major data stream. They cover everything from alcohol use to life expectancy, and you can compare national, state, and county levels. This comparison is key. Sometimes a county looks fine at the state level, but compared to the national average, it's actually in a lot of trouble. So, exam trick, if the test asks why compare all three levels, the answer is to identify local needs. Universities also provide resources. One well-known example is the University of Wisconsin's County Health Rankings. And when it comes to mental health, substance abuse, or suicide data, the Department of Health and Human Services is usually your best bet for that information. Once our map is built, we then have to verify the data. That means checking it against existing county or city needs assessments. Most counties publish these annually. The danger here is using outdated or redundant data. If a new pediatric clinic already fixed asthma ED spikes, we don't want to reallocate any of our resources to that particular problem that has been identified and then solved. Next is organizing the data. This is where the assessor makes the information usable, often in a spreadsheet, a chart, or bulleted list. The goal is to reveal both the strengths and the weaknesses that we have found. The data can be organized by category, gender, race, disease types, mortality rates, and then compared to the national, state, and the local levels. Visuals matter. Keep in mind, people love visuals. Charts and graphs are far easier for your stakeholders to digest than the raw data and bullet points. If you're ever writing a grant, trust me, pictures are going to tell the story. Make sure you are including these visuals. Statistical maps are another way of organizing. They visually show how factors like poverty, race, or employment correlate with disease outcomes, and which helps identify those health disparities. These maps can break down data even further. Median income, gender, employment, cardiovascular disease, stroke, diabetes, cancer, and mortality rates. Ultimately, they help identify geographic hotspots for interventions. Here's another exam tip for you. Statistical maps equal correlation finders, or that correlation finder. So that's clean definition, and the IBSC likes that. Statistical maps equal correlation finder. Then we move on to our gap analysis. The gap analysis looks at the holes in the healthcare system. It's usually done in a group format during the development of a community paramedic program. Stakeholders include hospitals, EMS, public health, and government officials. And W&C, you might invite local fire chiefs, nonprofit leaders, home health agencies. The idea is to find out what is missing. Mental health beds, transitional housing, or even transportation. We're trying to identify the gaps. This assessment inventories all community resources that can support patient care. The problem is lists are usually scattered and outdated. A strong CP program is going to bring leaders together regularly to update a shared resource guide. Sometimes this also can be called a care coordination council. Part of this assessment is documenting outreach services, programs that deliver care directly to the patients. That might be a mobile health crisis team, a home visiting nurse, or FQHC mobile clinic. As a CP, your job is to know what exists and maintain the most current, up-to-date list. Once you know what's out there, then you're going to build a web of resources. This catalog is organized by type of service, geography, eligibility, and hours of operation. Those 4 categories often do show up on exams as well. This web can be a printed guide, but more often now it's an online map. A really good example is that 504 HealthNet in New Orleans. If you haven't researched this, please look it up. It's not a homework assignment. Patients and providers can use it to find appropriate services quickly, and it's a fantastic resource. The mapping process should be collaborative. Hospitals should be listed first, especially if they already have community outreach programs, like CPR for new parents or diabetes education groups. Hospitals may also support subsidized clinics, including dental or vision care. Providers should be listed by their specialty: primary care, OBGYN, cardiology, pulmonology, endocrinology, geriatrics. Your role as a CP is not to duplicate these, but to help patients navigate and then connect them with these resources. A lot of times our best kept secrets are these outside resources. Employment services should be listed with clear requirements like background checks, physicals, or needing an address. Housing and shelter programs should be updated regularly since eligibility does change. And don't forget our mental health and substance use treatment options, including veterans resources as well through the VA. Extended care and transitional facilities like nursing homes or assisted living centers should also be included. The key contacts here are usually social workers or those case managers. Community and religious organizations are sometimes overlooked, but they can provide food, clothing, or home repair. Special needs services like Easter Seals, the Red Cross, and autism organizations also belong in this web. Transportation is critical. List bus vouchers, paratransit, hospital shuttles, anything that you can think of regionally. Finally, include safety net programs such as cash transfers, food stamps, or utility assistance. In Western North Carolina, Mountain Mobility is fantastic, or our Apple County Transit. These are lifelines for many of our patients. So let's apply this. We're going to imagine a 55-year-old man who repeatedly visits the ER for depression, heart failure, and heavy alcohol use. As a community paramedic, you're going to educate him on his condition, reinforce medication compliance, and connect him to primary care. You'd also link him with behavioral health support using that web of resources that we've developed. The referral process is where the rubber meets the road. Don't just hand a patient a brochure. Make the call for them. Depending on protocols, that could be you, a case manager, or a social worker. And whenever possible, involve the patient directly in the call to build the independence that they so desperately need. As the CP, you are the navigator, ensuring the patient is seen as a whole person, not just a diagnosis. A little more trick here for your IBSC. They love the terminology, a warm handoff. That language, warm handoff, it's the direct connection that beats passive referral every time. So that pretty much wraps up our Chapter 9. In this presentation, we've covered what a community health needs assessment is, how maps and data bring health disparities into focus, and how community paramedics use these tools, along with gap analysis and resource webs. That's to truly care for the whole patient. Before we close, I want to point out to you additional resources that I did add under your My Course. So you've got, under your PowerPoint, you've got your community-based needs assessment guide from the U.S. Department of Health and Human Services. This is a really, really helpful tool. It will walk you through a structured federal level framework for assessing community needs. It gives you examples, approaches, and explains how to engage stakeholders and highlights ways to collect and validate data. For us, it reinforces that what you've just learned by showing how national best practices line up with what you're doing here in Western North Carolina. So as you study, make sure you download that resource. It's going to help connect the dots between what we've covered in this chapter and how that large-scale assessments are being conducted nationwide. The bigger perspective is also something the IBSC exam is likely to test on, knowing not just what a CHNA is, but how it fits into the broader system of community health planning. And that's all I have for you guys today. I will check back in with you guys with Chapter 10, which will be coming up next. As always, stay safe, reach out if you have any questions, thoughts, or concerns.